Наступна доповідь у нас Павел Грабала «Хірургічне лікування тяжкого та запущеного сколіозу у дітей та підлітків».
Hello, thank you very much for the invitation to be a part of this great event. I am Pawel Grabala, I am a pediatric spine surgeon in Poland and perform complex spine cases in pediatric population. I'm going to talk about surgical management of severe and neglected scoliosis in children and adolescents. My disclosure: there are many classifications of spinal deformities in children and adolescents, but I think the most important and practical for surgeons are basic etiological classifications, which divide the deformities due to their etiologies like idiopathic, congenital, neuromuscular, syndromic, or other types. The very important classification based on age of child distinguishes early onset scoliosis less than 10 years old and late onset scoliosis more than 10 years old. You can see an example of early onset scoliosis, a child about 4 years old with severe early onset idiopathic scoliosis. This is the next example of early onset congenital scoliosis, a rare type of kyphosis with dislocation. The next example of late onset scoliosis is the girl with severe adolescent idiopathic scoliosis. The definition of severe scoliosis or severe spinal deformities includes deformities with a cup angle more than 90 degrees. Surgical treatment can be challenging and difficult with a higher risk of complications. You can see the next patient, 17 years old girl with severe IIS. The goals of surgical treatment consist of deformity correction and improvement of appearance, stop curve progression, improve pulmonary function and health-related quality of life, improve mobility, daily activity and growth. We need to avoid compression of the spinal cord, compression of the thoracoabdominal structures, neurological deficits and cardiopulmonary compromise. For surgical strategy, we use for AS cases Lanke's classification and rules, halo gravity traction, osteotomies, very rare 3-column osteotomies, and for congenital scoliosis, halo gravity traction, 3-column osteotomies. A typical case, AIS, 17 years old girl, posterior spinal fusion with multi-level Ponti osteotomies and direct vertebral derotation. You can see very good outcome. What we need for good correction and minimal risk of complications: good exposure and good view of anatomical structures, adequate pedicle screw placement as a solid base for correction maneuvers, posterior release techniques, facet joint resection, interspinosus ligament removal, Ponti osteotomy, thoracoplasty, 3-column osteotomy. Pedicle screw in spinal deformity can be challenging. Pedicle morphology, often only cortical channel or absent pedicle channel. Smaller pedicles than in adults. Severe curves and irrealistic angulation of screw placement. Larger screw diameter, better stability and power for correction deformity. But when we use larger screw and larger rods, we can receive better correction without higher risk of complications. There were published several papers about biomechanical rules. Our latest study showed also benefits for using larger screws and more powerful rods like 6.0 cobalt chromium. The study showed that pedicles in children are very flexible, and we can use larger screws, about 60, 70 or 80% without risk of breakage of medial wall. You can see a CT scan of small cancellous channel or cortical channel and pedicle screw placement with expanding of pedicles. The gold standard for spinal deformity correction is Ponti osteotomy. The target of this technique is well known and published in the literature. This surgical technique allows for lengthen the posterior column, provides better coronal correction, provides better axial plane correction, and complete disarticulation of posterior elements. Here you can see a very good view for outcomes of multi-level Ponti osteotomy and using 6.0 cobalt chromium rods with direct vertebral rotation of spine. Clinical pictures with good outcomes. We can also use other techniques like internal destruction, anterior-posterior release, thoracoplasty, osteotomy, apical spine resection, or combination of several techniques, anterior-posterior traction, release. Temporary internal destruction rods, first introduced by Bukowski et al. In 2006. Next, some modifications performed by Toll and Skaggs. Alternative to high-risk 3-column osteotomy provides a significant corrective force directly to the spine. This technique allows destruction under neuromonitoring, one-stage surgery or staged surgery. Final stage performed from 4 to 10 days after temporal rods are inserted, and average curve correction of 53% range, 39% to 79%. There are examples of Skaggs technique. You can see destruction during surgery. In 2020, Professor Helenius and I described the new alternative technique for temporary internal destruction rods, less invasive approach with Ponti osteotomies and staged surgery. In first stage, less invasive temporary internal destruction using less invasive approach, similar to putting growing rods with 2 short incisions, and the second stage for final correction. You can see the technique similar to growing rods. Final correction and fusion performed during the second stage, 2 to 6 weeks after the first operation, Ponti ostomies on the apex of the curvature, and segmental bilateral pedicule screw placement on the apex, and final correction with replacement of the titanium alloy rods using 2 contoured 6.0 cobalt chromium rods. You can see the example of severe AAS case. We perform staged surgery with temporal internal destruction rods, and final outcome during follow-up. Similar case and the same surgical technique with a good final result. Next case, 17 years old girl with severe IIS, surgical treatment with less invasive temporal internal destruction rods, and radiological and clinical outcome. In Italy, surgeons described the modification of Bukowski techniques using magnetically controlled growing rods for destruction. This is a similar idea to Bukowski and Skaggs techniques, similar wide open approach, multi-level Ponti osteotomies, destruction of 1 to 3 mm per day for a mean total 14 days, or 5 mm every 5-7 days. After receiving adequate destruction, final fusion. And this is example for literature. My experience with MCGR as temporary internal destruction device, 2 wide open approaches and surgeries, difficulties in adequate bending and rods placement, not for every severe scoliosis case, not good for kyphoscoliosis, difficulties in destruction course, never destructed more than 2.5 centimeters. This is my severe AS case, treated with MCGR as temporary internal destruction rod. You can see surgical technique and good radiologic outcome, and finally very good clinical outcomes during follow-up period. And good radiologic outcome, and finally very good clinical outcomes during follow-up period. In our study we conducted that there is no benefits in using magnetically controlled growing rod as temporary internal destruction device in staged surgical procedure compared to traditional halo gravity traction. You can see patient with severe kyphoscoliosis treated with halo gravity traction. We also compared halo gravity traction treatment course to less invasive temporary internal distraction rods. The outcomes are similar. This example of 14 years old girl with severe AS treated with less invasive temporary internal distraction rods and staged surgery. You can see clinical pictures before surgical treatment and radiological pictures before and after surgery, and of course clinical outcomes. Combination of several techniques, halo gravity traction, posterior release, ribs osteotomy, for treatment course of 16 years old girl with severe AS. You can see very good radiological outcomes and very good clinical outcomes. Main goals of spinal deformity treatment of early onset scoliosis: limb deformity progression, preserve spinal growth, obtain a balanced trunk and spine, lung development and pulmonary function, avoid TAS. We have many systems for treatment early onset scoliosis. I think the best one are still growing rods because they are less invasive for children. We have standard growing rods, magnetically controlled growing rods, and the newest, minimal invasive controlled growing rods. A surgical technique is similar to all growing rods. Our less invasive technique was published, and you can see on the pictures less invasive approach for growing rods placement. On the next slide you can see 9 years old girl with early onset idiopathic scoliosis treated with growing rods with our less invasive surgical technique. You can see X-ray before surgical treatment and after surgery. Next case, very severe early onset idiopathic scoliosis. You can see clinical pictures with severe deformity. X-rays before surgery present severe scoliosis and kyphosis. The child was treated with preoperative halo gravity traction by 6 weeks. You can see halo gravity traction and X-rays after surgical treatment and clinical pictures after putting growing rods. The next case is severe early onset idiopathic scoliosis. 2 years old child was 130 degrees. We put her MCGR, and after 7 years you can see very good outcome. The big challenge are congenital scoliosis, multi-level anomalies of spine. Congenital scoliosis may include wedged vertebra, hemivertebra, fused vertebra, missing vertebra as well as fused ribs. Type of anomaly: failure of segmentation, failure of formation, mixed types. Type of anomaly due to progression per year. Most of congenital scoliosis are associated with other anomalies. All abnormalities can be seen in MRI. Severe congenital scoliosis management: hemivertebrectomy for single or double hemivertebra, growing rods for multi-level vertebral anomalies, halo gravity traction, hybrid constructions, combination connections, all above techniques. 5 years old boy carry spinal cord syrinx, congenital kyphoscoliosis with dislocation. You can see MRI and compression of spinal cord, dislocation of spine in CT scan, protraction films and 6 weeks of halo traction, and surgical treatment, vertebral column resection of L1 and posterior spinal fusion with short fusion. You can see clinical pictures and X-ray after surgical treatment. Very good correction without any complications. Next case, 5 years old girl, congenital kyphoscoliosis. We perform PVC-RT 3T4. You can see X-rays before and after surgical treatment. Hemivertebrectomy from posterior approach is effective if performed early. Transpedicular eggshell osteotomy and radical vertebrectomy are common used methods of hemivertebrae excision by posterior approach. 3-year-old boy, congenital scoliosis, hemivertebrectomy from posterior approach L1, L2. You can see solid fusion 3 years after surgery. Growing rods for multi-level congenital anomalies. 7-year-old girl, multi-level congenital anomalies, poor bone quality. You can see X-rays before surgical treatment. First stage, halo gravity traction, screw placement with bone graft, and 3 months of halo gravity traction. After 3 months of halo gravity traction, minimally invasive controlled growing rods were used. You can see X-rays before and after surgical treatment. Next case is 5-year-old girl, multi-level vertebral anomalies, congenital scoliosis. We use her halo gravity traction 3 months, and after halo gravity traction, 2 levels posterior vertebral column resection T9 and T level, contralateral bar osteotomy, and one side MCGR placed. Next case is 13-year-old girl, neglected congenital kyphosis. We perform her vertebral column resection from posterior approach with the reconstruction of anterior wall. Next case, 16-year-old boy, congenital scoliosis, vertebral column resection and posterior spinal fusion. Be aware that Adamkiewicz artery really exists. Last case is 13-year-old boy, congenital kyphosis scoliosis. We use him 6 weeks of high gravity traction, multi-level ponte osteotomies, and perform posterior spinal fusion without vertebral column resection. You can see very good correction in 3 planes. In summary, the treatment depends on the curve size, etiology of deformity, progression scoliosis, child age, patient's family expectations, treatment risk and complications, possible outcomes. Many techniques we can use, but the safety at first. Thank you for your attention.
Thank you, Pawel Grabala, for the interesting presentation.